What is rehab or rehabilitation? My name is Fred Bigueras, a board-certified sports and spine medicine physician in Virginia Beach, Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab Podcast. This is a podcast episode on why treatments fail. I think this is a pretty interesting topic because it is a little bit more nuanced than I think both patients and even physicians realize. So after 10 years of practice, this is kind of my list and my thought process as to why things may or may not work. So I will start with kind of the low-hanging fruit or the obvious ones. The first one is that the treatment is just simply ineffective. Again, this is assuming that the diagnosis is correct, and for the most part, all of these examples, let's assume that the diagnosis is correct. The treatment may just flat out be ineffective. Just because something doesn't work doesn't mean that it actually technically failed. It sounds a little backwards, but not everything responds to everything. I think that's kind of the assumption, is that everything can have an effect. It's just a matter of picking the right tool. But not everything works. Sometimes things are just the way that they are, or the disease has progressed. The next topic is underdosing. When it comes to medications and even home exercise programs and things like that, sometimes the dosing is underdosed, meaning I will prescribe something as a twice-a-day medication, and the patient only takes it once a day. And there might be a couple different reasons as to why they only took it once a day versus twice a day. Sometimes there's a side effect. Sometimes they just don't like medications. There are certain medications that do have to build into your system. A common one that I use is gabapentin, or also known as Neurontin. It is not a medication that usually works off of the first dose. You have to kind of build it into your system, and you have to build it slowly. And that's sometimes why a medication is perceived as a failure, because the time to therapeutic benefit is too long, and patients will typically want symptom relief pretty quickly. And when it takes too long, they report back that it is ineffective. And gabapentin is a good example because it has a very, very classic or very predictable side effect, is it can sometimes make people feel sleepy. But it's not a medication I use to work right away. And that sometimes can confuse people, because sometimes people will just want to take medications and have it work as soon as they swallow, but realistically, not all medications work that way, and you do have to invest some time into it, but it sometimes just simply doesn't work. Another potential option or reason why something fails is that not every condition has a silver bullet, and there needs to be a multifactorial approach. So there's not simply one tool, but you have to use multiple tools. So a good example is an injection by itself for the knee versus an injection plus physical therapy might be a better long-term outcome versus just doing one or the other. And again, that does test people's patience and their pocket as well. Again, no treatment, at least in the U.S., is free. And every now and then it has to be one or the other, because that's all the patient can afford. And that definitely needs to be taken into account in terms of helping the patient understand why things worked or did not work, and where to go. Now, the next reason is that sometimes the disease or the condition is simply just too far gone. I'll use arthritis as an example. There's mild arthritis, and then there's severe arthritis. And the milder forms of arthritis tend to respond more predictably compared to the more severe forms. And there's sometimes a point where certain conservative treatment options just simply don't work anymore. And that's not necessarily because the tool doesn't work. It's just that sometimes the disease or the condition has progressed. And that definitely needs to be taken into account. Conversely, I have had some experiences where the patient was not willing to try even the conservative management because in their mind, there's just no way that it could possibly work because their arthritis is quote unquote bone on bone. And clinically, that hasn't been the case. I've definitely seen severe arthritis respond really well to conservative treatment, and vice versa. Very mild arthritis sometimes actually needed a surgical intervention. That leads us into the next topic of expectations. Now, as a physician, it is, I believe, a major goal to set appropriate expectations, not only for the disease prognosis, but also how they expect their patient to respond to the treatment. Should they expect a positive response quickly versus a couple of days? Are there any side effects that they should note? If the treatment does work, how long is it going to last? Now, that's a lot of the treatments are very unpredictable, so giving your best guess is still pretty much a guess, but I do think patients appreciate it when I try to give them a rough idea of how long I think this is going to last. The last thing that I'll mention is essentially a miscommunication between the patient and the physician. There are situations where I have said something and that was not exactly what the patient heard. Humans are creatures of habit, and when it comes to certain treatment recommendations, there's just certain things that I say repetitively and certain things that I just never really say. And there are plenty of studies where, what was said wasn't what was heard. And I've definitely experienced that where I will tell a patient what I think and then I'll have them repeat it back to me pretty much right afterwards. And not to say that they weren't listening, but sometimes what they repeat back to me is completely not what I said. So even when I hear, I see patients that have also seen other physicians prior to me, so I'm kind of like a second opinion. I sometimes have to take their interpretation with a grain of salt. I will always ask them what their takeaway was from when they saw another physician, but I do have to realize some of the limitations and the biases that we all carry. And this isn't a patient thing, this is a human thing. So it is very important for us to check back in with our patients to make sure that they heard what they heard so that the expectations are met appropriately. The next topic is going to be about personal beliefs in terms of the patient. Sometimes, the power of belief is very strong. And, whether or not the patient believes in the treatment, to me, is actually a very big predictor of how they respond and how they do in the long run. Explaining the condition, the mechanism of action, and how the treatment is supposed to counteract that, I believe it makes a big difference, because if it doesn't make sense to the patient, there's a good chance that they're not going to think that this is going to work. And even if it does work, and we've all seen this before where there's objective evidence that, their range of motion has improved, or that they are walking and doing more with less pain, yet their perception is that it's not working. Sometimes it's because they just don't believe that that's what they need, even though objectively we can measure improvement. If it doesn't make sense to them, it might not actually work. And this sometimes actually plays into self-sabotage. I've had, plenty of patients over the years that have said, the only reason why I'm seeing you is because my insurance is requiring me to do this, or I know that you have to order physical therapy because that is what my insurance is telling you to do. And, there's definitely some truth to that. Unfortunately, when you do play the insurance game, you play by their rules. But it kind of does it's kind of a self-fulfilling prophecy in that sense, and it's a form of self-sabotage that even if this was the the protocol that has to be played. When you just generally believe it's not going to work because of that, again, you're kind of fulfilling that negative outcome. It works both ways. If you believe wholeheartedly that something is going to work, the chances that it works are pretty good. The second comment I get a lot is the Band-Aid analogy, that this treatment is just the Band-Aid. That's kind of like a trigger word for me. I'll have to kind of go into a different that might be for a different podcast episode. But again, when someone only believes that what is being done is simply a Band-Aid, in their mind they already know that there's another option that's better for them. And I know what some of you must be thinking is that's rather presumptuous. Maybe they're just simply stating a question. But I'll tell you, after 10 years, I've given just about everybody the benefit of the doubt. I have changed essentially no one's mind if they bring up the Band-Aid analogy that any of my treatment options are going to work. And I'm a pretty good communicator. I really take the time to talk about all the treatment options, their concerns, and why do they believe it's a Band-Aid or it's not going to work. And I'm telling you, it's I've never really changed anyone's mind. So it kind of has become a sign that, it's a kind of a poor prognostic sign that they're going to improve with a conservative treatment plan. Personal beliefs and the power of suggestion, it works as well from who people listen to. I think it's very important to know your patient in that sense of who they listen to, who's important in their life. I've definitely had my share of patients that have said, my neighbor said that this epidural injection didn't work for them. And even though I know that there's some nuances when it comes to treatment options and indications for epidurals and the different potential sources for back pain, no matter what my experience level is and what knowledge level I have to share, the patient trusts their neighbor's opinion, which is why they brought it up. That's really difficult to overcome sometimes. And I have had in some of those cases where, I just never really approached that topic again because, again, they were already very hesitant. They don't believe that it worked for their neighbor. So, they kind of in their mind decided it wasn't going to work. So, similarly, I have had some fellow physicians shoot me in the foot by telling my patients that, oh, those treatments aren't going to work because what you need is surgery, and they still refer to me anyways. That doesn't do me any good either. So physicians do carry weight when they talk to patients sometimes. So I do think we need to watch how and what we say to our patients because, again, the power of suggestion is very, very strong. The last thing I'll mention is personal interactions. I think this is, definitely appreciated by anyone that's ever been to received healthcare, been to the emergency room, a doctor's office, physical therapist. The interaction between the physician and the patient is very important. The physician can be very competent and be the most skilled, but if they have really bad bedside manner, there's a good chance that the patient is not going to follow up with that particular person. There's a good chance that the patient is going to have a negative association, not only with the physician, but any of the treatment options that the physician talked about. That is why sometimes a treatment option is perceived as a failure, when in actuality it is a failure of the physician to connect with the patient. The next thing is also staff. I have definitely had some great physician colleagues not get follow-up because the staff just was really, really bad. I wish I could say it a different way, but I'm talking about the front desk. the staff taking the blood pressure, all those little things. You ask any business owner, they know the value and the power that the staff have, but it can also play a role in the patient's perception of the treatment. So I think in the past positions that I've held, I might have seemed a little bit controlling with my staff when it comes to how I want the staff taking the blood pressure, all those little things. You ask any business owner, they know the value and the power that the staff have, but it can also play a role in the patient's perception of the treatment. So I think in the past positions that I've held, I might have seemed a little bit controlling with my staff when it comes to how I want certain things to be done in the office and how I want patients to be talked to, because I have never for a second undervalued the power that interactions that patients have with me and with my staff. It's extremely important to the success of a treatment plan. Again, I just wanted to have this discussion about some other reasons that treatment options may not be as favorable as we've hoped, and why some of our patients draw the conclusions that they do when we think something is effective and they don't. I hope you guys look at this as just some food for thought. Determining that a treatment is a failure or is ineffective is actually a lot more nuanced than it may seem. And I hope that this does spark some discussion among your colleagues and also your patients. Thank you for listening to the Talking Rehab podcast. I hope that this podcast stimulates you to question your own practice and how you approach rehabilitation. I truly appreciate your time and attention. If you enjoyed listening, make sure to like and subscribe to the podcast. I wish you a movement-filled day. Take care.